Okay. So about now, if you could hear my voice and see the screen properly, type yes on the chat box. I'm so sorry it was on mute. We had a small technical glitch. If you could hear my voice and see the screen properly, type yes on the chat box. If you could hear my voice and see the screen properly, type yes on the chat box. Okay, much better. So as per the Pinali's law, we are having a FeV1 FVC ratio, which is 80%. And if it is less than 80%, it indicates there is an obstructive lung disease. So in a normal individual, FeV1 will be normal, FVC will be normal, and FVC ratio, FeV1 FVC ratio will also be normal. But in the obstructive pattern, you see there is a decrease in the FeV1. You see there is a decrease in the FeV1, and there is a normal or decrease in the FVC ratio, so that you can able to see the overall FeV1 FVC ratio would have been decreased here, And then you have the restrictive lung disease. Speaking about the restrictive lung disease, we have the FeV1, FVC, both ratios will be decreased. So since the numerator is also decreasing, denominator is also decreasing. So either FeV1, FVC ratio will be normal, or the FeV1, FVC ratio will be elevated. Okay. So what type of FeV1, FVC ratio you may see? Decrease in the FeV1, FVC ratio is seen in obstructive, normal or increased is seen in restrictive. Very, 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 very important MCQ in terms of your respiratory physiology. Okay, then you have obstructive and restrictive pattern of diseases. What type of diseases comes under the obstructive pattern, and what type of lung diseases comes under the restrictive pattern, people? Speaking about the obstructive lung disease, we are having an asthma and the COPD, which is a chronic bronchitis and emphysema. And then you have the bronchiectasis, cystic fibrosis, and bronchiolitis. All comes under the pattern of your obstructive, while restrictive is entirely divided into extrinsic and intrinsic, people. We divide the restrictive as intrinsic and extrinsic. So speaking about the extrinsic and intrinsic, the intrinsic diseases are like the pneumoconiosis, for example, whatever the bassinosis, bagosis, whatever the acquired diseases will come under the intrinsic pattern, while you have the sarcoidosis, pneumoconiosis, idiopathic pulmonary fibrosis, and anything that can be induced, like a drug or radiation induced interstitial lung disease, you may see it as a restrictive pattern. And then you have the extrinsic one. Extrinsic one comes under either a neuromuscular disease or maybe due to the chest wall disease. So chest wall, it is due to the kyphoscoliosis or obesity or maybe ankylosing spondylosis. You may expect to see that there is a bamboo spine in here, which is another important MCQ. Bamboo spine and HLA-B27 is a very, very important MCQ they may ask you. So apart from that, you may see also the restrictive lung disease pattern in these diseases. Okay, and then you have the neuromuscular diseases such as diaphragmatic palsy and Guillain-Barré and muscular dystrophy and the cervical spine injury. You may see it as an intrinsic neuromuscular diseases which can contribute to restrictive pattern of your lung diseases. Okay, so this is all about the obstructive and restrictive lung disease. So what is the tidal volume? The amount of air inspired and expired in a normal breathing is so-called as tidal volume. What is the inspiratory reserve volume? Whenever the air is exhaled more than the tidal volume, I mean more than the normal breathing, it is a forceful breathing. The excessive air which is inhaled is so-called as inspiratory reserve volume. The excessive air which is exhaled out is expiratory reserve volume. Whatever which is present over, still there are some air in the lungs which cannot be pumped out. That air is so-called as residual volume. And vital capacity, inspiratory plus tidal volume plus residual volume. While total lung capacity, IRB plus TV plus ERB plus RB. All four will combine to form a total lung capacity. And inspiratory capacity, that is a tidal volume plus inspiratory reserve volume. So all of the things which contribute for this lung parameters, you have to know Pinali's law. What is Pinali's law? FeV1 FVC ratio should be 80%. If it is less than 80%, it indicates there is an obstructive pattern of your diseases. Okay, next is the muscles of breathing. We studied that in the anatomy. Anyway, we talk about the major muscles, only the major muscles. For inspiration, diaphragm and external intercostal is the main one. And for expiration, you have the internal intercostal and external and internal obliques, and rectus abdominis are the important one. And these are the main muscle which involves in the inspiration and expiration. I'm not doing it again this part because we already covered that in the anatomy. Okay. Then we are going to talk about certain lung parameters. We are going to talk about certain lung parameters. First one is your compliance. Speaking about the compliance, compliance is a change in the volume by change in the pressure. Change in volume divided by change in pressure. That is a del V by del P is your compliance. Compliance is inversely proportional to elastance. That means more and more compliance, less and less elastance. Okay. And what are the conditions that can increases your compliance of your lung? And what are the conditions that can decreases the compliance of your lung? So the condition that can increases the compliance of your lung are emphysema, flail chest, emphysema, flail chest, and sternotomy. And what are the conditions that can able to decrease your lung compliance? The ones which can able to decrease your lung compliance are you're gonna mark it in red: pulmonary fibrosis, consolidation, pulmonary edema, obesity, kyphosis, and ankylosing spondylosis. Kyphosis and ankylosing spondylosis are the conditions that can able to decreases your compliance. Okay. And apart from that, what are the different types of compliance we are having? The different types of compliance we are having are: one is your static compliance, where you see compliance measured when there is absence of breathing, and dynamic compliance may be measured when there is a presence of breathing. Okay, when there is a presence of breathing. And then you have a specific compliance, where compliance is divided by your functional residual capacity of your lung. Okay, FRC of your lung. That is so called as compliance. So what are the things you have to know about the compliance? Del V by del P. Static compliance and is measured when absence of breathing. Dynamic compliance is measured when there is a presence of breathing. And the compliance is inversely proportional to elastance. And the conditions affecting compliance are that are increase in the compliance is seen in the emphysema, flail chest, and sternotomy, while there is a decrease in the compliance is seen in pulmonary fibrosis, pulmonary edema, ankylosing spondylosis, kyphosis, obesity, and lung consolidations. Okay, and lung consolidations are the where are the situations where you see there is a conditions which has been showing a decrease in the compliance of your lung. Okay, so this is all about the compliance. Then the next parameter we are going to talk about is your resistance. Speaking of resistance, the major site of resistance is your medium-sized bronchi, while the resistance can be measured with 8 rho L divided by pi R power 4, where rho is the viscosity of a lung, or rho is the viscosity, L is the length, and R is the radius. Okay, so I directly says that resistance is directly proportional to the length of the surface, length, and inversely proportional to the 4th power of the radius. Okay, resistance is directly proportional to the length and viscosity, and inversely proportional to the 4th power of the radius. And what are the factors which is affecting your resistance? We used to classify these factors as, due to the muscle contraction and lung volume and viscosity. Viscosity, as we said, rho is a viscosity, so resistance directly proportional to viscosity. No problem. And what about the lung volume? Whenever the lung volume have an inverse relations with the resistance. So whenever the lung volume is increasing, then that's the time you see the decrease in resistance. And similarly, whenever the lung volume is decreasing, that's the time you see the increase in the resistance. Okay, and then muscle contraction mediated by sympathetic and parasympathetic, as we all know that parasympathetic causes bronchoconstriction. So there is an increase in, increase in the resistance, and whenever there is a sympathetic nervous system, there is a dilation. So you may see there is a decrease in the resistance. There is a decrease in the resistance. Then you are talking about the ventilation coefficient ratio, V by Q ratio. V by Q ratio is 0.8. The V by Q is more at the apex and less at base. Very, 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 very important MCQ in terms of FMG people. Very, 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 very important MCQ that you should not miss. Okay, more at the apex and less at the base. Okay, and V by Q is 0 when ventilation is 0. If V by Q is 0, that means ventilation is 0. What are the conditions that can cause us obstruction in the ventilation? Foreign body, bronchoconstriction due to asthma, compression of airway by the tumor, or collapse of lung, or pulmonary fibrosis, water in the lung. Anything that can goes into the passage can able to make the ventilation 0, because the lung is not properly ventilating due to the obstruction of any of the substance, either a foreign body or the tumor or the air, or maybe the lung has been collapsed or the lung has been fibrosed so that it cannot able to ventilate properly. Any of the situation may contribute to the V by Q ratio of 0. And when will you see the V by Q ratio of infinity? Something with the denominator of 0. Yes or no? That is a perfusion is 0. That means the condition where the lung can be ventilated but cannot be perfused. What are those conditions? Very, very important condition is your pulmonary embolism. Very, very important condition is your pulmonary embolism. Apart from that, you may have the compression of pulmonary vessels, and you have the tumor, which can occlude your pulmonary vessels. Anything related to the pulmonary vessels that can able to cause your impaired perfusion, so that you may have the proper ventilated lung, but there is no perfusion happening there. Okay, so these are the basic parameters of your respiratory physiology. Then we talk about the gas exchange, transport of O2, mainly from the dissolved form and combined with the oxygen. Combined with the hemoglobin, or maybe due to the, like a dissolved form. So oxygen carrying capacity of your arterial blood is 19.8, and oxygen carrying capacity of your venous blood is 15.2 ml of oxygen. You should remember that. Maybe they ask you with the memorized question, but it is very rare, but you may have a chance that they may ask you this. Okay, then you have a O2 dissociation curve. This is kind of like a 3-star to 5-star rated topic, people I rather say. 3-star to 5-star rated topic. What are the factors that can shift your oxygen dissociation curve to left, and what are the factors that can shift your oxygen dissociation curve to right? So the factors which can shift your oxygen dissociation curve to left are decrease in temperature, decrease in PCO2, and increase in pH, and other hemoglobin types such as fetal hemoglobin and methemoglobin. Fetal hemoglobin and methemoglobin. While what are the factors that can able to shift the oxygen dissociation curve to right are, we used to due to the exercise, high altitude, and temperature, and pH, and PCO2 rise. Decrease in the pH and increase in PCO2. And apart from that, there is an increase in 2,3 BPG. Very, 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 very important. Because whenever in the high altitude where there is a more 2,3 BPG concentration, so rapid lubricant cycle will happen, so that the oxygen loses its capacity to hemoglobin loses its capacity to carry the oxygen. Yes or no? So increase in 2,3 BPG will increases the thyroid hormones and growth hormones, and decreases causes acidosis and stored blood. Okay, 2,3 concentration is increases in thyroid hormone and growth hormone, and it also decreases the acidosis and stored blood. Okay, then its concentration is decreases in acidosis and stored blood. Okay, then you have the transport of carbon dioxide. It will be in the 3 form, either a bicarbonate, carbamino, or dissolved form. Bicarbonate, carbamino, and dissolved form. Apart from that, you have a DELCO, the diffuse lung capacity of your carbon monoxide. CO uptake by PCO2 in alveolar air is a formula, but normal value is 25 ml per minute. These are all loyal, but what is the important one is what are the factors that can rise your DELCO, and what are the factors that can lower your DELCO? What are the factors that can rise your DELCO, and what are the factors that can lower your DELCO? So the rising of a DELCO is seen in bronchial asthma, Mueller maneuver, exercise, supine position, polycythemia, alveolar hemorrhage, obesity, high altitude, and in the morning. And for decrease in DELCO, we used to remember it like pulmonary fibrosis, sarcoidosis, asbestosis, interstitial lung diseases, emphysema, lung resection, ventilation perfusion mismatch, anemia, bleomycin, amiodarone, methotrexate, PAH, pulmonary vasculitis, pulmonary edema, Valsalva maneuver, and pregnancy. There is no other option except you have to mug up people. Pretty long and large, yeah. But if you want to score that 1 mark from this respiratory, yeah, you have to do that. Yeah, you have to do that. So the increase and decrease in DELCO has been done. Now we are going to talk about the breathing reflexes. Speaking about the breathing reflexes, the one is your Herring-Brewer inflation reflex. That is, overinflation can prevent the further lung inflation. And then you have this Herring-Brewer deflation. That is, deflation increases the ventilatory rate. And then you have the paradoxical reflex of head. Inflation of lung causes a further inflation. Inflation of lung causes a further inflation. Those are all the breathing reflexes you have to know. Apart from that, there are certain abnormal breathing pattern out there. You have to remember that. One is your chain stroke respiration, where you see the period of apnea and hyperpnea. Okay, where you see the period of apnea and hyperpnea. Okay, so apart from that, you have the BIOCHEMISTRY breathing or ataxic breathing, which is due to the damage to your medullary respiratory regulation center, where you see the irregular inspiration, which is separated by the long period of apnea. Okay, irregular inspiration, which is separated by long period of apnea. And then you have a Kussmaul breathing. You know the Kussmaul breathing. So regular, deep, and fast respiration is Kussmaul breathing. And Ondain's curse. Ondain's curse is also known as congenital hypoventilation syndrome, where there is a loss of involuntary control of your breathing during the sleep. And apneustic breathing, prolonged inspiratory spasm or damage to your pons can result in the apneustic breathing. So important abnormal breathing pattern, people. Chain stroke, which is apnea and hyperapnea, and BIOCHEMISTRY breathing or ataxic breathing, irregular inspiration, which is separated by long period of apnea. And then you have the Kussmaul respiration, regular, deep, and fast one. And then you have the Ondain's curse, loss of involuntary control of your breathing during sleep, and apneustic breathing, prolonged inspiratory spasm. Yeah, Kussmaul is seen in any type of metabolic acidosis, not only a DKA. We are having a variety of metabolic acidosis. That too, we can able to split the content into like increased anion gap and metabolic acidosis and normal anion gap metabolic acidosis. Yes or no? So among that, we see that there is a DKA falls under one category. That technically Kussmaul is seen in any type of a metabolic acidosis with the respiratory compensation. You know, as a respiratory compensation to any type of the metabolic acidosis, you may see the Kussmaul's breathing. Okay, these are the image-based questions that you may expect to see here. You know, like a normal and restrictive pattern, obstructive pattern, and mixed upper airway obstruction, and variable extrathoracic and variable intrathoracic obstruction. You may be seeing in this condition. Quite an image-based question. They may ask you what type belongs to the asthma and what type belongs to the pneumoconiosis, blah, blah, blah. They may ask you. Okay, but no need to worry about that. You can get it easily. Okay, then we are talking about the endocrine physiology. Speaking about the endocrine physiology, the first area we are going to talk about is your pituitary gland. One is your anterior and posterior pituitary gland. So anterior pituitary gland is also known as adenohypophysis, where it contains 5 cell types which secrete 6 hormones, while the posterior pituitary is also known as neurohypophysis, where it secretes only 2, supraoptic nucleus, ADH, and paraventricular nucleus, oxytocin. Okay, while the anterior one, somatotrope secretes growth hormone, lactotrope secretes prolactin, gonadotrope secretes FSH and LH, thyrotrope secretes TSH, corticotrope secretes ACTH. Corticotrope secretes ACTH. So all 6 can be secreted during this process. Okay, then growth hormone. Speaking about the growth hormone releasing hormone will be there in the hypothalamus, and then it releases the growth hormone from the anterior pituitary. Once it enters into the anterior pituitary, it goes to the target tissues. In the target tissues, it will stimulate the production of 4 things. What are they? One is your somatomedins production or insulin-like growth factor production, and decrease in glucose uptake because there is an insulin-like growth factor is acting, and increase in lipolysis and increase in protein synthesis and increase in lean body mass. Okay, increase in lean body mass. Technically, it stimulates insulin-like growth factor production. So that in turn causes a decrease in the glucose uptake, like increase in lipolysis and increase in protein synthesis. Okay, while there is an excess will causes gigantism and acromegaly, while deficient causes dwarfism. You know that already. Very easy one. Yes or no? Then you have the prolactin. The function of prolactin is, number 1 is stimulation and inhibition. Both are there. So inhibition The prolactin is stimulated by, is used for the milk production and breast development. Okay, it stimulates milk production and breast development. And for inhibition, it inhibits ovulation by decreasing synthesis and release of your GnRH, and it will also inhibits the spermatogenesis. So technically, prolactin is a hormone of female, so it inhibits the spermatogenesis, and it also inhibits the ovulation by decreasing the synthesis and release of your GnRH. While stimulation for breast development and milk production, it stimulates. Okay. Then you have those factors. What are the factors that can stimulate the prolactin synthesis, and what are the factors that can suppress the prolactin synthesis? Factors stimulates prolactin synthesis. Quite important 3-star rated topic, people. You should not miss. Factors stimulates prolactin synthesis. Is your estrogen and breastfeeding, sleep, stress, TRH, and dopamine blockers. And then inhibition of prolactin, that is a dopamine, bromocriptine, somatostatin, and prolactin. Dopamine, bromocriptine, somatostatin, and prolactin. Among the dopamine is a very important one. You should not miss it. Dopamine inhibits prolactin. Dopamine inhibits prolactin. And then you have a posterior pituitary hormone, ADH action. It can stimulate the aquaporin formation, and it can reabsorb the water and the sodium in the distal collecting duct and the distal convoluted tubule. And it also can produces your vasoconstriction. It can also produces your vasoconstriction. And oxytocin, you know oxytocin, ejection of milk and contraction of uterus. And the factors that can stimulate oxytocin are suckling reflex and dilation of your cervix, and your orgasm can able to stimulate the oxytocin. Okay, so this is all about the pituitary one, main pituitary hormones. Okay, growth hormone, prolactin, ADH, and oxytocin we are seeing. So growth hormone, it can stimulate the ADH synthesis, or it can stimulate the IGF synthesis or somatomedin synthesis that can decreases your glucose uptake, increases lipolysis, and increases your protein synthesis and your lean body mass. Deficiency causes dwarfism, excessive in children causes gigantism, and adult causes acromegaly. While prolactin, it stimulates milk production and your breast development. It inhibits ovulation and spermatogenesis. Okay, and the factors which can able to stimulate prolactin are estrogen, breastfeeding, sleep, stress, TRH, and dopamine blockers. While here you may see exactly the opposite. The inhibition are dopamine, bromocriptine, somatostatin, and prolactin. Okay, and apart from that, you have the posterior pituitary hormone, ADH, formation of aquaporins, reabsorption of water and the sodium in the distal convoluted tubule and collecting duct. While you have this oxytocin, milk ejection and contraction of uterine, that is a uterotonic, and you have this milk ejection function. And the factors that can able to stimulate the oxytocin are suckling reflex, and you have this dilation of your cervix. Dilation of your cervix. So this is all about the pituitary. Shall we move on to the thyroid gland? So moving on to the thyroid gland, we are having a thyroid hormone synthesis, people. The first one we are having is a thyroid hormone synthesis. So first one is your thyroglobulin synthesis. So thyroglobulin is synthesized by your thyroid follicular cells. And then it can be stored and it can be packaged and it can be excreted in the lumen. So here you have the thyroglobulin which has been synthesized, and then it has been protruding and it has been reaching your lumen. And then we have the sodium iodide co-transporter. Sodium iodide co-transporter, which can actively transport the iodine to your thyroid follicular cell. And then this iodine will be iodide ion, I minus ion, that means iodide ion will be converted into iodine by this thyroid peroxidase enzyme or TPO enzyme, which then transport the iodine into the follicular lumen, and then it will peroxidize it. Okay, it will peroxidize it, and then it will form a monoiodothyronone and diiodothyronone. Monoiodothyronone and diiodothyronone. So in the follicular lumen, what will happen is this monoiodothyronone and diiodothyronone will combine to form a T3. If the two diiodothyronone are there, then they combine to form a T4. Then they combine to form a T4 and stored in the follicular cells. And then whenever it is necessary, it will be it will be thrown into the blood for the circulation whenever the thyroid hormone is less. Okay, fine. T3 and T4 has been circulating, but we are having a lot of a T4. So we need a T3 more. So we have this 5-deiodinase enzyme. 5-deiodinase enzyme will break down the peripheral conversion of T4 to T3. Will break down the T4 into T3 peripherally. Okay, this is all about the thyroid hormone synthesis. So thyroglobulin synthesized and packed in the follicular cells, iodine transported by the sodium iodide transported, then organified by the peroxidase and converted into monoiodothyronine and diiodothyronine, and then they combine with the thyroglobulin to two diiodothyronine to combine to form a T4, and one monoiodothyronine and one diiodothyronine combined to form a T3. And then they can be stored whenever necessary. It can be moving. Okay, and what are the functions of your thyroid hormone? It works synergistically with the growth hormone for linear growth, and apart from that, it can cause a maturation of CNS, increase the activity of beta-1 receptor in the heart, increases O2 consumption and increases your basal metabolic rate, increases synthesis of sodium potassium ATPase, increases cardiac output, increases glucose absorption, glycogenolysis, gluconeogenesis, and lipolysis. Very, 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 very important functions of a thyroid hormones are. Okay, and hypothyroidism and hyperthyroidism. Hypo is due to iodine deficiency, cretinism, and Hashimoto thyroiditis, apart from the surgical removal of thyroid gland. And hyper is due to the Graves' disease or neoplasm. Graves' disease or neoplasm. Then we are having adrenal cortex, zona glomerulosa, fasciculata, and reticularis. All of them, aldosterone, cortisol, and androgen will be synthesized by them. Aldosterone, you know that it is a part of your RAS and can able to cause an increase in the sodium absorption and increases in potassium secretion. And cortisol, it can stimulate gluconeogenesis. It is an anti-inflammatory and immunosuppressant. So anti-inflammatory is due to the synthesis of your lipocortin and inhibition of IL-2 and inhibition of histamine and serotonin. Okay, fine. Apart from that, what are the diseases which can be caused due to the ACTH? Increased ACTH causes Addison's, decreased ACTH causes Cushing's syndrome, increased ACTH causes Cushing's disease, and apart from that, increased aldosterone will causes Cone syndrome. This is all about the adrenal cortex. Okay, then we are talking about the endocrine pancreas, alpha cell, beta cell, and delta cell. Alpha secretes glucagon, beta secretes insulin, and delta secretes somatostatin. And you already know their functions, so I don't want to insist much and more in the case of your endocrine because it is very easy to understand. Next is your calcium metabolism and homeostasis, which has been done by 3 hormones. One is your PTH, vitamin D, calcitonin. Here I want to insist you a few things, people. Here I want to insist you a few things. One is the important MCQ they may ask you to confuse us, which vitamin can act as a hormone. Which vitamin can act as hormone? Which vitamin can act as hormone? That is the question they may ask you, people. The vitamin that can be act as hormones are your vitamin D. That is your 1,25 dihydroxy cholecalciferol. Okay, 1,25 dihydroxy cholecalciferol. So speaking about that, calcium metabolism and homeostasis, 3 hormones is mediating it. One is your PTH, one is your vitamin D, and another one is your calcitonin. Calcitonin add the calcium to bone. Remember that. Calcitonin add the calcium to bone. Calcitonin add calcium to bone. Adds the calcium to bone. So it will decreases the resorption of your bone. Very, very important MCQ. Exception and in terms of negation, they ask you this question more and more. Okay, calcitonin decreases resorption of bones, while PTH and vitamin D exactly does the opposite function. It takes the calcium from the bone and throws it into the blood. It takes the calcium from the bone and then throws it into the blood. And kidneys, it takes the calcium from the kidneys, reabsorbs, and along with the phosphate but there is a difference between the PTH and vitamin D. Is PTH will decrease phosphate reabsorption and increase calcium reabsorption, while vitamin D does the both. And intestine, it can increases the calcium absorption, and vitamin D also increases the calcium absorption. Okay, so this is all about the calcium metabolism and calcium homeostasis. So the last portion we came here in your physiology is your reproductive hormones and the menstrual cycle, and then lactation. So we are going to talk only about the highlights here, not we are going to talk every single point. So this thing can be asked as an image-based question, people. Male reproductive hormones and their control. So hypothalamus secretes GnRH, anterior pituitary secretes FSH and LH, and FSH will stimulate the Sertoli cells, and LH will stimulate the Leydig cells. Okay, LH will stimulate the Leydig cell. Sertoli cells will secrete inhibin, which in turn inhibits your FSH, while Leydig cells will secrete testosterone. Leydig cells will secrete testosterone, will further stimulate the Sertoli cells to secrete inhibins to suppress FSH, and it also inhibits your LH and GnRH as a product inhibition or negative feedback control mechanism. Okay, so this image may be asked, and anywhere they put a bracket and they ask what is A, what is B, what is C. Remember, Sertoli cell secretes inhibin, Leydig cell secretes testosterone. You have to remember these two things at least. Sertoli cell secretes inhibin, Leydig cell secretes testosterone. And Sertoli cells are stimulated by FSH, Leydig cells are stimulated by LH. Sertoli cells are secreted by are stimulated by FSH, while the Leydig cells are stimulated by LH. You have to remember that. Okay. Then you have the menstrual cycle. This is a male hormone. We are talking about the female hormone. So we are having a follicular phase, ovulation phase, luteal phase, and then menstrual phase. Follicular phase, ovulation phase, luteal phase, and menstrual phase. So follicular phase, where you see the increase in estrogen and decrease in progesterone, primordial will grow into Graafian follicle. Primordial will grow into Graafian follicle, and ovulation is occurring in day 14, and LH surge occurs prior to the ovulation. Very important MCQ. LH surge occurs prior to the ovulation. Okay, then luteal phase. Speaking about the luteal phase, where you see the development of corpus luteum, and there is an increase in progesterone. And in the menstruation, where corpus luteum will be converted into corpus albicans, and then sloughing off of your endometrium will happen there. Then there's lactation. Lactation is a 5-star rated topic, people. You should not miss. Estrogen and progesterone causes a growth of your breast. Estrogen stimulates prolactin secretion and then produces milk synthesis. Oxytocin produces milk ejection. Estrogen and progesterone, growth of breast. Estrogen, prolactin secretion, milk synthesis. Oxytocin, milk ejection. You should know these things in a perfect way, people. So with this, we are completing our entire physiology. We do 10 minutes of revision, and then we take a 10 minutes of break, and then we come back and we do the biochemistry by 6 o'clock. Is that okay for you? Shall we do the 10 minutes of revision, people, of your entire physiology? Shall we do 10 minutes of revision for our entire physiology? LH surge is a classical example of what type of feedback mechanism? LH surge is a classical example of what type of feedback mechanism? It's a positive feedback mechanism. So what is the dye we use to measure your blood volume? Radioactive chromium-51 labeled RBCs we use. What is the total body water? How much percentage is your total body water out of your total body weight? 60%, which is measured by deuterium, tritium, and antipyrin. Deuterium, tritium, and antipyrin. Chronotrophy relates to heart rate, bromotrophy relates to cardiac conduction velocity, and bathmotrophy relates to cardiac excitability. Ionotrophy relates to myocardial contractility. Lucitrophy relates to cardiac relaxation. P wave duration is 0.1, QRS duration is 0.8, and T wave duration is 0.2. ST segment is depressed in hypokalemia. Tall T waves are seen in hyperkalemia, and PR interval denotes your AV conduction time. And S1 will be heard in isovolumetric contraction, S2 protodiastole, S3 rapid filling, S4 atrial contraction. S4 atrial contraction. A wave on JVP indicates right atrial contraction. C wave indicates isovolumetric contraction. A small sign is due to the increased JVP with inspiration, is seen in constrictive pericarditis, massive pulmonary embolism, RV infarct, restrictive cardiomyopathy, and restrictive cardiomyopathy. Okay, apart from that, you have the cardiac output formula, which is your heart rate into stroke volume, or by the direct fixed method, it is a O2 consumption by arteriovenous O2 difference. Indicator method, amount of indicator injected divided by concentration. That indicator dilution method is also known as Stewart-Hamilton principle. And regulation, cardiac output is equal to stroke volume into heart rate. So stroke volume depends on preload, afterload, and myocardial contractility. Preload, afterload, and myocardial contractility. What is the normal mean arterial pressure? 93.33. What is the normal mean arteriolar pressure? 93.333. Okay. What is the formula? Diastolic blood pressure plus 1/3 pulse pressure. Diastolic blood pressure plus 1/3 pulse pressure is your normal, what do we call it? Normal formula for your mean arterial pressure. And apart from that, you may have this thing, you may have the respiratory physiology. Speaking about the respiratory physiology, so tidal volume is amount of air inhaled and exhaled in a one proper respiration. What is a TLC? TLC is a all four volume. IRV plus EV plus ERV plus RV. What is FRC? ERV plus RV. What is inspiratory capacity? Tidal volume plus inspiratory reserve volume. What is Pinale's law? FEV1 by FVC is equal to 80%. Decrease in the 80% indicates obstructive lung disease. Okay. And then apart from that, compliance formula, del V by del P. Resistance formula, 8 rho L by pi r power 4. And ventilation perfusion ratio is 0 in ventilation defect, infinity in perfusion defect. And factors that can shift your oxygen dissociation curve to right are increase in PCO2, decrease in pH, increase in temperature, high altitude during exercise, and increase in 2,3 BPG. Increase in 2,3 BPG. And apart from that, you have the Herring-Breuer inflation. Overinflation prevents the further lung inflation. Herring-Breuer deflation. Deflation increases the ventilatory rate. Paradoxical reflex of head. Inflation of lung causes further inflation. Okay, and apart from that abnormal breathing pattern, periods of apnea and hyperapnea change stroke respiration. And Kussmaul's respiration, regular, deep, and fast one, which is seen as a respiratory compensation to your metabolic acidosis. Onden scars, loss of involuntary control of your breathing during sleeping. And ataxic breathing, irregular inspiration separated by long period of apnea. And apart from that, you have this GI physiology. Speaking about the GI physiology, we have the G cell secrete gastrin, I cell secrete cholecystokinin, S cell secrete secretin, kappa cell secrete GIP, D cell secrete somatostatin, Mo cell secrete motilin, and ghrelin will be stimulating your GH secretion. And apart from that, we are having two types of motility, reflex, defecating reflex. Feces will produce a rectal distension and relaxation of your internal and external sphincter. There will be producing a urge to pass the stool. And gastrocolic reflex, is the reflex where food will produces the distension of your stomach, and then it will produces a defecation. Consumption of food will produces a defecation sensation. And then you have this endocrine physiology. Hormones secreted by your anterior pituitary are growth hormone, prolactin, FSH, LH, TSH, and ACTH. Hormone decreases produced by your neurohypophyses are ADH and oxytocin. ADH and oxytocin. Apart from that, you have this thyroid gland and adrenal cortex. Zona glomerulosa produces aldosterone. Fasciculata produces cortisol. Reticularis produces androgen. Increase the ACTH is Addison's. Decrease the ACTH is Cushing syndrome. Increase the ACTH is Cushing's disease. And aldosterone tumor is your Cohn syndrome. And endocrine pancreas, alpha secretes glucagon, beta secretes insulin, delta secretes somatostatin. And apart from that, you have a Sertoli cell secretes inhibin, Leydig cell secretes testosterone, and then you have the follicular phase of a menstrual cycle having increase in estrogen, while luteal phase have a decrease in estrogen and increase in progesterone, and you see the formation of corpus luteum. Sloughing off of endometrium is occurring in the menstruation phase. Apart from that, milk ejection is done by oxytocin, milk synthesis is done by prolactin, and breast development is done by your estrogen and progesterone. And then you have the neurophysiology. Speaking of a neurophysiology, conduction occurs through the nodes of Ranvier as saltatory conduction. Slowest fiber is type 3. Most susceptible to hypoxia is type B. Most susceptible to pressure is type A. And apart from that, titin will connect the M line to Z line. Desmin will connect the 2Z line. Actinin will connect the actin to Z line. And dystrophin will add the strength to the muscle. And CIT troponin, C for calcium binds to troponin C, I inhibition of actin myosin interaction, P binds troponin components to tropomyosin. Troponin components to tropomyosin. Onion-like structure in the subcutaneous strain, which can able to detect vibration and tapping is Pacinian corpuscle. Present in non-hairy skin is your the one which is present in non-hairy skin is your Meissner corpuscle. Pressure is detected by Ruffini corpuscles. Location is detected by Merkel cell. Location is detected by Merkel cell. Flexion is carried out by rubrospinal. Extension is carried out by vestibulospinal. And respiratory muscle tone is carried out by reticulospinal. Auditory impulse by tectospinal. Voluntary movements by corticospinal. And then you have the dorsal column. Vibration, proprioception, and 2-point discrimination is carried out by dorsal column. Pain, temperature, crude touch is carried out by spinothalamic tract. Carried out by spinothalamic tract. So with this, we are wrapping up your physiology. So take a 10 minutes of break, and we see you by 6 o'clock. Have a nice day, people. Okay, so here we have completed the physiology and anatomy. Where we are moving on to our today's session to our biochemistry actually. Then we move on to the biochemistry. Speaking about the biochemistry, people, we are going to talk about a few important steps of the biochemistry. So high yield area of your biochemistry is where your carbohydrate, lipids, vitamins, and proteins. And nowadays they have been changing the portion patterns to your what do we call it? Nowadays they have been changing your question patterns to your vitamins and electron transport chain the more and more. Okay, so now speaking about this, we are having the first high yield area, which is your carbohydrates. We will discuss that first, and then followed by the lipids, followed by your remaining areas that you have to master here. Okay, now speaking about it, carbohydrate, the first thing we are going to talk about your carbohydrate is your isomerism in carbohydrate, people. The first thing we are going to talk about is your isomerism in carbohydrate. So what type of isomerism you may see it in the carbohydrate? What type of isomerism you may see it in the carbohydrate? That is your stereoisomerism and optical isomerism. That is your stereoisomerism and optical isomerism. So stereoisomerism are your enantiomers, anomers, and epimers, people. Your stereoisomerism are enantiomers, anomers, and epimers, while your optical isomerism is the one which is doing through the plane polarized light. So we first discuss about the optical isomerism, and then we discuss about the stereoisomerism halide. Okay. So optical isomerism, whenever you take a sugar solution and then you pass a beam of plane polarized light and check whether the light has been deviating or not. If the light has been deviating, then it is a you have to look for what direction does it deviate. Whether does it deviates to the right or to the left. If it deviates to the right, then we used to call that as dextrorotatory or small d. We used to call that as dextrorotatory or small d. If it deviates to left, then we used to call that as levorotatory or small l. Then we used to call that as levorotatory or small l. Okay. Now, speaking about that, what if the plane polarized light does not deviate at all? What if the plane polarized light does not deviate at all? If the plane polarized light does not deviate at all, then that sugar solution contains equal amount of D and L sugar, which is your racemic mixture. Now here I wanted to add the one more important MCQ here, people. The important MCQ I'm gonna add here is your sucrose is so called as invert sugar. Sucrose is so called as invert sugar. Why? Sucrose is so called as invert sugar. Why? Because sucrose contains an equal amount of the D-glucose and the L-fructose. So sucrose contains what sugar? Equal amount of D and the L sugars. That is the D-glucose and the L-fructose. But what the problem is, because it should be a racemic mixture, right? Whenever we pass the plane polarized light, we cannot able to, we need to check whether the light is deviating or not. Sucrose contains a D glucose and L fructose, yes or no? So it should be the racemic mixture. It should not deviate. But because of the strong levorotatory nature of your fructose, the plane polarized light deviates to left. So that's why sucrose is so called as invert sugar. Why sucrose is so called as invert sugar? Because of the strong levorotatory nature of your fructose. That is your L fructose. Because of the strong levorotatory nature of your L fructose, we used to call that sucrose as the plane polarized light deviates to the left, and then we used to call that as a invert sugar. Okay, sucrose is so called as invert sugar. Now, coming back to the stereoisomerism, speaking about the stereoisomerism, we have enantiomers, ionomers, and epimers. So enantiomers is totally based upon the orientation of your penultimate carbon. Orientation of your penultimate carbon. If the penultimate carbon means what? Second last carbon. How do you number the carbon? From the functional group. From the functional group, the second last carbon is your penultimate carbon. Yes or no? If that penultimate carbon orientation, you have to check it out. If the penultimate carbon orientation is on the right, then that sugar is a capital D sugar. If the penultimate carbon orientation is on the left, then that sugar is a capital L sugar. Okay, so you have to, it is solely based upon the penultimate carbon orientation. Then you have the cyclization. Cyclization of your sugar is so called as anomers, where you used to get alpha and beta forms. And the ringed structure or cyclized structure of the sugar, especially the glucose is so called as pyranose, while the fructose is so called as furanose. That's the thing they may ask in FMGE when they are checking about the basics of your carbohydrate. Then you have the epimers. C2 epimer of glucose is mannose, C3 epimer of glucose is allose, and C4 epimer of glucose is galactose. What is epimer? Two structure which have similar structure but different in spatial orientation other than the penultimate carbon is so called as epimers. For example, like I rather uses the allose here. All the OH group is on the right side. All the OH group is on the left side. Then that is a allose. All the OH group on the right side is a D-allose. And then if the glucose contains the third OH group on the left side, that is a difference in the orientation. The only orientation is your third carbon OH group on the glucose is on the left side, but the third carbon OH group on the allose is on the right side. That's why we used to call that as a epimer. So C3 epimer of glucose is your allose. So this is how it will be. Now, next important things on your basics is important oligosaccharides. So maltose contains glucose and glucose, while sucrose contains glucose and fructose, while lactose contains glucose and galactose. While the lactose contains glucose and galactose. Then, whenever you treat the carbohydrates with the phenanthrene compound, then you may get a flavored substance called as ozozones. So ozozones might be asked sometimes as a like a basic ones. So what type of ozozones? Maltose is a sunflower shaped ozozone, lactose powder puff shaped ozozone, monosaccharide needle shaped ozozone. Okay, maltose sunflower, lactose powder puff, and monosaccharide needle shaped ozozone has been formed. Okay, so far these are the basic things about the carbohydrate. Pretty loyal. They may ask you, I rather say like 1 star to 3 star. If they want to irritate you with the tough questions, then at the time they may put you this type of questions. Okay. Apart from the test for carbohydrate, here we have the variety of tests. Among that, the important test is overall test for carbohydrate is Mollish test, and test for reducing substance is Benedict test, and test to differentiate aldoses and ketosis is Sullivanov test, rapid for Feautres and Feautres test, and the test for pentosis is Bial's test, and test for starch is E-iodine test. These are the tests where you have to remember that. Okay. Well, one time they asked an FMG as this as a question, like all of the following sugars shows positive test to Benedict, except was the question. The answer is the sucrose, because sucrose is a non-reducing sugar. Nowadays, it has been discovered like a partially reducing sugar. So sucrose is a non-reducing sugar. Sucrose do not form ozozones, and sucrose is an invert sugar. You have to know these 3 points regarding the sucrose when it comes for the basics. Then we talk about the important category here, people. This page is kind of like one of the page that you have to remember. You should not miss it. So the one of the important page here, GAG and their mucopolysaccharidosis. GAG and mucopolysaccharidosis. One of the important GAGs are mentioned here. So the first GAG is your hyaluronic acid. The content of hyaluronic acid is D-glucuronic acid plus N-acetyl glucosamine. And chondroitin 4-sulfate, D-glucuronic acid plus N-acetyl galactosamine 4-sulfate. And dermatan sulfate is L-hyaluronic acid plus N-acetyl galactosamine 4-sulfate. And keratin sulfate is N-acetyl glucosamine 6-sulfate plus D-galactose. And heparin is D-glucuronate 2-sulfate plus N-sulfoglucosamine 6-sulfate. And heparin is D-glucuronate 2-sulfate plus N-sulfoglucosamine 6-sulfate. Okay, is the heparin. So now speaking about that, you are having this hyaluronic acid. How do you remember this contents of this important gag? I used to remember it like, I used to remember the hyaluronic acid, that is your D-glucuronic acid plus N-acetyl glucosamine. Plus N-acetyl glucosamine. N-acetyl glucosamine. I used to remember this hyaluronic acid content. This D-glucuronic acid is also seen in chondroitin sulfate, except the second part. Chondroitin sulfate except the second part, which is the N-acetyl galactosamine 4-sulfate. The different structure is N-acetyl galactosamine 4-sulfate. Galactosamine 4-sulfate. And this N-acetyl galactosamine 4-sulfate is also common in your dermatan sulfate. Dermatan sulfate, exception is the first part where you see instead of D-glucuronic acid, L-hyaluronic acid you may see. Hyaluronic acid you may see. Apart from that, this N-acetyl glucosamine is also seen in the keratin sulfate. Also seen in keratin sulfate. The only difference is instead of D-glucuronic acid, you may see D-galactose on the keratin sulfate. D-galactose on the keratin sulfate. So this is how I used to remember the important gag. Okay, hyaluronic acid, D-glucuronic acid plus N-acetyl glucosamine. The D-glucuronic acid is common in hyaluronic acid and your chondroitin sulfate. So what's the different structure? N-acetyl galactosamine 4-sulfate is a different structure in the chondroitin sulfate. That N-acetyl galactosamine 4-sulfate is also common in the dermatan sulfate, except the content is L-hyaluronic acid is in the L-hyaluronic acid, you may see it in the dermatan sulfate, while D-glucuronic acid, you may see it in the hyaluronic acid. Okay, apart from that, N-acetyl glucosamine is also seen in keratin sulfate, where the difference is D-galactose. Okay, most common gag present in cartilage is chondroitin, present in your skin is dermatan, present in your eye is your keratin, and keratin sulfate is the only gag with the no uronic acid residue. Very, 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 very important MCQ. Only gag with no uronic acid residue. Only gag with no uronic acid residue is your keratin sulfate. Very, 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 very important MCQ. Mark it out. Only gag with no uronic acid residue is your keratin sulfate. And then mucopolysaccharidosis. Speaking about that, the important one is your Hurler and Hunter. So Hurler syndrome is due to the alpha-L iduronidase. Hunter is due to iduronate sulfatase, while Martax-Lamy is due to aryl sulfatase B. These are the prominent question which has been asked. These are the prominent question which has been asked. Among that, Hurler syndrome, where you see the corneal clouding, while Hunter syndrome, there is no corneal clouding. No corneal clouding. No corneal clouding, and it follows X-linked recessive pattern. It follows what pattern, people? X-linked recessive pattern. These are the two things you have to remember in terms of your Hurler and Hunter. Hurler, alpha-L iduronidase, where you see the corneal clouding, and features of mucopolysaccharidosis. Apart from that, you have iduronate sulfatase deficiency, which is your Hunter's. Features are similar to Hurler's except corneal clouding, because which is absent in the Hunter's. And apart from that, it may show the X-linked recessive pattern. Apart from that, it may show the X-linked recessive pattern. Then you have the aryl sulfatase B, where you see the Martax-Lamy's disease. Deficiency causes a Martax-Lamy disease. Okay, with this, we have completed the basics. Now we are going to talk about the digestion and absorption of your carbohydrate. Speaking about the digestion and absorption of your carbohydrate, One is your polysaccharide. So whatever the carbohydrates we are taking is in the form of the polysaccharide. So it goes into your mouth, and then you have the salivary amylase or ptyalin, which can able to break that polysaccharide into mono and oligosaccharide. How? You take the polysaccharide or the carbohydrate in the form of polysaccharide, and then you chew it in your mouth. Your mouth contains the enzyme. We studied that in your digestive physiology, that it is a salivary amylase or ptyalin. Ptyalin breaks the polysaccharides into mono and oligosaccharides. Ptyalin breaks the polysaccharides into mono and oligosaccharides. And then this mono and oligosaccharides will pass us down to your stomach. And ptyalin, remember one fact, that ptyalin will not work whenever the pH is less than 3.0. Ptyalin will not work whenever the pH is less than 3.0. So no digestion is happening in the stomach. And then it goes to your intestine, where it meets with your pancreatic secretion and bile duct secretion, all those things. We have this pancreatic amylase enzyme, which break down this further mono oligosaccharides into monosaccharides. Further oligosaccharides into monosaccharides, and we have certain intestinal specific disaccharidases like a maltase, sucrase, lactase enzyme, which will break down their respective carbohydrate into their monosaccharide. For example, maltase will break the maltose to glucose plus glucose. Sucrase will break the sucrose to glucose plus fructose, and similarly lactase will break the lactose to glucose plus galactose. So all of things have been broken down, and it has been converted into monosaccharide and get absorbed in the duodenum and jejunum. And it get absorbed in the duodenum. So we have till now, whatever we talked was a digestion of carbohydrate. Polysaccharide, salivary amylase, breaking into mono and oligo. Is there any digestion happens in the stomach? No. And then it goes to intestine, where pancreatic amylase breaks the further oligosaccharides, and disaccharidases breaks the further disaccharides into mono, and it gets absorbed. How is it getting absorbed? In the absorption, we have two types of mechanism is there. One is your secondary active transport, another one is your facilitated diffusion. One is your secondary active transport, another one is your facilitated diffusion. We already studied that in your general physiology yesterday. Okay, right. Secondary active transport is mediated by, as I said, SGLT 1 and 2. One is on the intestine and another one is on the kidney. And the GLUT, facilitated diffusion, is mediated by glucose transporter GLUT. And GLUT is of two types, either an insulin dependent one or non-insulin dependent one. Either an insulin dependent one or a non-insulin dependent one. Insulin dependent glucose transporters are GLUT4. Insulin dependent glucose transporters are GLUT4, where you see skeletal muscle, cardiac muscle, and adipose tissue. Where you see skeletal muscle, cardiac muscle, and adipose tissue. And apart from the non-insulin dependent one are GLUT1 and 3, which is placental specific, GLUT1, which is present in RBC and brain, and GLUT5, which is a fructose specific. Okay, fructose specific, where you may see it in the small intestine, sperm, and kidney. And apart from that, this is how the glucose is getting absorbed via two mechanisms: secondary active transport and facilitated diffusion. Facilitated diffusion is mediated by GLUT, which is of two types: insulin dependent, non-insulin dependent. Insulin dependent one is GLUT4, where adipose tissue, cardiac muscle, and skeletal muscle. This was one of the old important question. Nowadays they are not asking this, but previously, if you are looking at any past Q bank, this type of questions was asked nearly 10 to 12 times. Okay, this is the change of pattern of question, people, where they are shifting the topics from carbohydrates to the vitamins. Okay, so glycolysis. So speaking about the glycolysis, the first metabolism of carbohydrate involves the glycolysis. We're not going to talk about the entire cycle here. We are going to talk about the highlights, whatever you need to know for the exam. Don't be worried. Everything has been covered here. Easily you can score a good marks. Easily you can score a good marks if you follow it up. So glycolysis. What is meant by glycolysis, people? Glyco and lysis. What is meant by glycolysis? Glyco and lysis. Lysis means breakdown. So breakdown of glucose. So is it a complete breakdown of glucose? No. It's not the complete breakdown of glucose. You have to remember the fact that it's not a complete breakdown of glucose. It is the breakdown of glucose into 3 carbon compounds. It is a breakdown of glucose into what? Into 3 carbon compound. What is the 3 carbon compound? In the presence of oxygen, it is a pyruvate. In the absence of oxygen, it is a lactate. Remember, glycolysis is not a complete breakdown of glucose because this was asked several times as a question of negation. You should remember, glycolysis is not a complete breakdown of glucose. It is a breakdown of glucose into 3 carbon compound, namely pyruvate in the presence of oxygen and lactate in the absence of oxygen. Okay, in the absence of oxygen. And what is the net ATP gained? The net ATP gained at the end of aerobic glycolysis is 7, while net ATP gained at the end of anaerobic glycolysis is 2. The net ATP gained at the end of aerobic glycolysis is 7, while in the anaerobic glycolysis it is 2. Okay. Then what are the 3 irreversible steps of glycolysis? The 3 irreversible steps of glycolysis are number 1, hexokinase or glucokinase, and phosphofructokinase and pyruvate kinase. Okay, what are they? Hexokinase or glucokinase, phosphofructokinase 1, and then you have this pyruvate kinase. So hexokinase or glucokinase, hexokinase causes decrease in Km, decrease in Vmax, and also inhibited by glucose 6-phosphate, while glucokinase, it is present in liver and it is stimulated by insulin. It is present in liver and it is stimulated by your insulin. This was one of the important MCQ area, people. Hexokinase and glucokinase difference was one of the important MCQ area that you should not miss. Okay, so what are the 3 irreversible steps? Hexokinase or glucokinase, phosphofructokinase 1, and pyruvate kinase. So what is the regulation of your glycolysis? Arsenate and iodoacetate inhibits glyceraldehyde 3-phosphate dehydrogenase, while fluoride ion inhibits enolase. While arsenate and iodoacetate inhibits glyceraldehyde 3-phosphate dehydrogenase. Okay, glyceraldehyde 3-phosphate dehydrogenase. Then you have a PDH complex. What are the requirements of PDH complex? We used to remember with the mnemonic of TLC for Nancy, or tender loving care for Nancy. Tender loving care for Nancy. Tender loving care for Nancy is the requirement for your PDH complex. T stands for thymine pyrophosphate, L stands for lipomide, C stands for coenzyme A, F stands for FAD, N stands for NAD. Is this tender loving care for Nancy is required only by the PDH complex? Is this tender loving care for Nancy is required only in the PDH complex? No. There are 2 other complexes which also uses this tender loving care for Nancy. What are they? One is your alpha ketoglutarate dehydrogenase complex. Alpha ketoglutarate dehydrogenase complex, and another one is your branched chain keto acid dehydrogenase complex. Another one is your branched chain keto acid dehydrogenase complex will also uses this tender loving care for Nancy. That is your TPP, lipomide, coenzyme A, NAD, and FAD. Okay. What are the enzymes present in your PDH complex? What are the enzymes which are present in your PDH complex? One is your pyruvate dehydrogenase enzyme, PDH enzyme, dihydrolipoyl transacetylase enzyme, and dihydrolipoyl dehydrogenase enzyme. Why I wrote it here? I should have skipped the PDH complex, but there was a question in FMGE that all of the following enzymes belongs to PDH complex except was the question. All of the following enzymes belongs to your PDH complex except was the question. So no problem. You can able to remember and you can able to answer this question. Pyruvate dehydrogenase, dihydrolipoyl transacetylase, and dihydrolipoyl dehydrogenase. Dihydrolipoyl dehydrogenase are the 3 enzymes which belongs to your PDH complex. Are the 3 enzymes which belongs to your PDH complex. Then you have a TCA cycle. So we have talked about the glycolysis. We have talked about the PDH complex. So where does this glycolysis is happening? This glycolysis is happening in cytosol. This glycolysis is happening in cytosol. What is the PDH complex is doing? PDH complex is converting your pyruvate to acetyl-CoA. Pyruvate to acetyl-CoA. By taking up this tender loving care for Nancy, and these three enzymes will play a role, and then it converts the pyruvate to acetyl-CoA. And then this acetyl-CoA will enter into the mitochondria for the TCA cycle. So where does the TCA cycle is happening? It is in the mitochondria. What is the first substrate for TCA cycle? It is a pyruvate or acetyl-CoA. Whatever you see in the option, you can mark it. So remember, TCA cycle is an amphibolic pathway, and TCA cycle is a amphibolic pathway. That means both anabolic and catabolic reaction take place, and TCA cycle is strictly aerobic, people. TCA cycle is strictly aerobic. Okay, and what is the rate limiting enzyme of your TCA cycle? That is your isocitrate dehydrogenase. That is your isocitrate dehydrogenase. And one TCA cycle yielded 10 ATP. What is the net ATP gained at the end of TCA cycle? That is 10 ATP. Okay, one TCA cycle can give rise to 10 ATP. And what is the regulation? Number one is a fluoroacetate inhibits aconitase enzyme. Iodoacetate inhibits alpha ketoglutarate dehydrogenase enzyme. And malonate inhibits succinate dehydrogenase enzyme. And malonate inhibits succinate dehydrogenase enzyme. So these are the three enzymes which plays a regulation of your TCA cycle. Fluoroacetate inhibits aconitase. Iodoacetate inhibits alpha ketoglutarate. Malonate inhibits your succinate dehydrogenase. Malonate inhibits your succinate dehydrogenase. Okay, then this is all about the complete breakdown of glucose. So they may ask you the question in this pattern to people. What is the complete, where does the complete breakdown of glucose is happening? In the mitochondria. Okay, in the mitochondria. If they're given you a cycle, then TCA cycle. So where does the complete oxidation of glucose is, or complete breakdown of glucose is happening? In the mitochondria. So in the mitochondria, you have to remember that. Okay, so we have talked about the complete breakdown of glucose. Now we are going to talk about the synthesis of glucose from the non-carbohydrate sources. That is so called as gluconeogenesis. So gluconeogenesis, people. That is gluconeogenesis. What is gluconeogenesis? Neo means new. Synthesis of new glucose. Synthesis of new glucose means gluconeogenesis. So what is the synthesis of new glucose? The synthesis of new glucose will be coming from your non-carbohydrate compound. From what compound? From a non-carbohydrate compound, you see the synthesis of new glucose. Okay, what is the non-carbohydrate compound? We have a 5 non-carbohydrate compound which can able to synthesize this new glucose. One is your pyruvate, another one is your lactate, another one is your alanine, another one is your glycerol and odd chain fatty acid. Glycerol and odd chain fatty acid. Now, speaking about this 5, how does this 5 can able to give rise to the glucose? So pyruvate to malate, oxaloacetate by pyruvate carboxylase, and oxaloacetate to malate. Malate will cross from mitochondria to cytosol, and then cytosol to oxaloacetate to phosphoenol pyruvate. Then fructose 1,6 bisphosphate to fructose 6-phosphate, mediated by fructose 1,6 bisphosphatase, and then glucose 6-phosphate to glucose by glucose 6-phosphatase are the 3 enzymes which plays a role here. So far pyruvate, reversal of glycolysis, we modified the 3 irreversible steps of glycolysis by the 3 different enzymes. Among that, the unique enzyme of your glycolysis is your PEPCK. Rate limiting enzyme of your glycolysis is fructose 1,6 bisphosphatase. And where do you see the gluconeogenesis is happening? Where do you see the gluconeogenesis is happening? In the organ, liver and kidney, in the organelle, cytosol and mitochondria. Very, 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 very important MCQ, people. You should not miss it. 7-star rated topic, gluconeogenesis. Whenever they want to ask you a question from the carbohydrate, gluconeogenesis is always their choice. And this page is kind of page that you can score at least one question, and we covered all the essentials related to the gluconeogenesis. Okay, unique enzyme of gluconeogenesis is FMGE. Rate limiting enzyme is fructose 1,6 bisphosphatase. Where does this gluconeogenesis is happening? In the liver and kidney, and in the intracellular organelle, both cytosol and mitochondria. So we have the first aid for USMLE, have a very fantastic mnemonic for that. Hug requires both was the mnemonic. Hug requires both was the mnemonic. H stands for heme synthesis, U stands for urea cycle, G stands for gluconeogenesis, which is so called as hug requires both cytosol and mitochondria. Hug requires both cytosol and mitochondria. Okay, so pyruvate, we have the unique enzyme is FMGE. Rate limiting step is your fructose 1,6 bisphosphatase. So after pyruvate, the second compound is lactate. Synthesis of glucose from lactate is so called as Cori cycle. Glucose from alanine is so called as Cahill cycle. And arch-chain fatty acid can form a methyl malonyl CoA to succinyl CoA to TCA cycle. Remember, I mentioned it as a note, very, 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 very important note. Your skeletal muscle do not contain glucose 6-phosphatase enzyme. What is that? Your skeletal muscle do not contain glucose 6-phosphatase enzyme, and your acetyl CoA can never be converted into glucose. One of the very, 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 very important MCQ people. Okay, that you should not miss. Your skeletal muscle do not contain glucose 6-phosphatase enzyme, and your acetyl CoA can never be converted into glucose. Your acetyl CoA can never be converted into glucose are the two things you have to remember, and you should not forget it. Next area of interest is your gluconeogenesis and glycogenolysis. Glycogenesis and glycogenolysis, synthesis and breakdown of glycogen. We simply say synthesis and breakdown of glycogen. Another 7-star rated image. This image, you cannot find it anywhere. Quite a very important image, and you should know that this whole image is kind of like a 7-star rated topic. You should not miss. Okay, first one, formation of glycogen. First one is the formation of glycogen. We have the glucose. Glucose will be converted into glucose 6-phosphate mediated by hexokinase or glucokinase. Mediated by hexokinase or glucokinase. And the glucose 6-phosphate will be converted into glucose 1-phosphate mediated by phosphoglucomutase. Mediated by what? Phosphoglucomutase. So remember one thing, this phosphoglucomutase belongs to glycogenesis. Okay. So phosphoglucomutase converts the glucose 6-phosphate to glucose 1-phosphate, and then this glucose 1-phosphate will be converted into UDP glucose. This glucose 1-phosphate will be converted into UDP glucose, and then UDP glucose to linear chain glycogen mediated by glycogen synthase. Mediated by glycogen synthase, which is considered to be the rate limiting step of your glycogen synthesis or glycogenesis. So what is the rate limiting enzyme of glycolysis? Phosphofructokinase 1. What is the rate limiting enzyme of your TCA cycle? Isocitrate dehydrogenase. What is the rate limiting enzyme of gluconeogenesis? Fructose 1,6 bisphosphatase. Now we are seeing the rate limiting enzyme of glycogenesis. What is it? Glycogen synthase. What is that? Glycogen synthase. Then linear chain glycogen to normal glycogen. Linear chain glycogen to normal glycogen by the branching enzyme. By the branching enzyme, deficiency of this branching enzyme could result in type 4 glycogen storage disease called as Anderson's disease. Type 4 glycogen storage disease called as Anderson's disease. And glycogen will be either broken down or there is a minor glycogenolysis will happen by the enzyme acid maltase. By the enzyme acid maltase, and deficiency of this acid maltase could result in glycogen storage disease 2, Pompe's disease. where you see the cardiovascular defects, CVS defect. So pompase affect your pump is the mnemonic. Okay, pompase affect your pump is the mnemonic. Then glycogen will be further broken down into glucose 1-phosphate mediated by two enzymes. What are they? Debranching enzyme and glycogen phosphorylase enzyme. Debranching enzyme and glycogen phosphorylase enzyme. Among that, your glycogen phosphorylase is a rate limiting enzyme of your glycogenolysis, people. Among that, your glycogen phosphorylase is a rate limiting enzyme of your glycogenolysis. Okay, so debranching enzyme deficiency could result in Cory's, which is type 3, while glycogen phosphorylase defect on liver causes HERS, which is type 6, and muscle, which is McArdle's type 5. Okay, M for M and H for H. Hepato, HERS, muscle, McArdle's. You have to remember in that pattern. Okay, then you have a glucose 6-phosphate to glucose 1-phosphate. Glucose 1-phosphate to 6-phosphate, 6-phosphate to glucose by glucose 6-phosphatase. Deficiency in liver causes von Gerke's disease. Deficiency causes von Gerke's disease. So insulin stimulates glycogenesis, while glucagon and epinephrine stimulate glycogenolysis. You should know that. Okay, so all the regulations, steps, enzymes, and diseases, everything was covered in a single page or single image. This image is kind of like a gold standard image for you people. So you should be taking it up and piling it up like you have sitting in the car and you're preparing 1 hour before the exam. You want to read some page. This is one among the page that you should not miss. This is one among the page that you read while going prior to your morning exam, and recall it and definitely you get a question. Okay, so I will tell you what are the pages that you should read 1 hour before the exam. You should read at least 5 to 10 pages. Among that, I told you one on the anatomy, I told you one on the physiology, and I'm telling you now for the biochemistry. So at the last, you have to know that there are certain things you have to read at the last moment to keep everything in your mind and answer it right. Most probable mistake you make during the time is like you don't know exactly, your answers will become blurry. Okay, you know it is something like 6.2, but you don't know what exactly it is. You know something, it starts with a P, but you don't know what exactly it is. So to master that blurring, you need to read certain pages prior moving on to the exam. So this is one among those pages you have to remember that. Okay. So now the last area, that is your HMP shunt and the glucose and galactose metabolism. So HMP shunt, the main purpose of your HMP shunt is formation of NADP and formation of pentosis. Very, 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 very important. Formation of NADP. Till now, whatever we have seen was NAD. Formation of NADP and formation of pentosis are the main purpose of your HMP shunt. And what is a rate limiting enzyme? Another important MCQ. Rate limiting enzyme of your HMP shunt is glucose 6-phosphate dehydrogenase. Glucose 6-phosphate dehydrogenase deficiency causes X-linked recessive hemolytic anemia. X-linked recessive hemolytic anemia. We have seen one more X-linked recessive disease back in a mucopolysaccharidosis. What was that? We have seen one more, like X-linked recessive disease back in our mucopolysaccharidosis in the biochemistry. What was that? Hunter's disease. Okay, Hunter's disease. Okay, where the characteristic features were Heinz bodies and bite cells. Again, this image is a pathology image, but it can also be asked as a biochemistry question. Either like a Heinz bodies or bite cells. Can any one of this can be presented here. Okay, so for this, and then you have the galactose metabolism. Speaking about the galactose metabolism, either the rate limiting enzyme is your galactose 1-phosphate uridyl transferase. Deficiency causes galactosemia, where you see the oil drop cataract in the galactosemia. Snowflake cataract is seen in diabetes mellitus. Sunflower cataract is seen in Wilson disease. You have to remember that. Okay, you have to remember that too. Then you have a fructose metabolism. Speaking about the fructose metabolism, we have one hereditary fructose intolerance is due to aldolase B def. Essential fructosuria is due to fructokinase def. Essential fructosuria is due to fructokinase def. So till now we have completed the carbohydrate. We have completed the carbohydrate. So there are certain important things we have covered. So one was your basics of carbohydrate. So we revise it in a very faster manner. So that you can able to understand most of the things in your carbohydrate. Okay, first one. So what is the rate limiting enzyme of glycolysis? PFK1. Rate limiting enzyme of gluconeogenesis is fructose 1,6 bisphosphatase. Snowflake cataract is seen in diabetes mellitus. Sunflower cataract is seen in Wilson disease. Oil drop cataract is seen in galactosemia, which is due to galactose 1-phosphate uridyl transferase deficiency. And essential fructosuria is due to fructokinase deficiency. Hereditary fructose intolerance is due to aldolase B deficiency. Aldolase B deficiency. X-linked recessive hemolytic anemia is due to G6PD deficiency. So among the G6PD is a rate limiting enzyme of HMP shunt, while the two main purpose were your synthesis of pentoses and synthesis of NADP. Synthesis of glucose from lactose is via Cori cycle. Synthesis of glucose from the alanine is via Cahill cycle. So we take a 5 minutes of break. Someone is knocking on my door. We'll get back. Okay, very sorry for that. So with that, we have completed our carbohydrate. So far, we can able to proceed with okay. So far, we can proceed with the next area of interest, which is your lipids. So speaking about the lipids, the very first highlights on the basics is speaking about the lipid. The very first highlight on the basics is omega-3 and omega-6 fatty acid. So omega-3 fatty acid are cervonic acid, timnodonic acid, and alpha-linolenic acid. And omega-6 fatty acids are gamma-linolenic, linoleic, and arachidonic acid. Gamma-linolenic, linoleic, and arachidonic acid are the omega-6 fatty acid. Okay, among that, arachidonic acid is a semi-essential fatty acid, and it is responsible for the synthesis of prostaglandin people. It is responsible for the synthesis of prostaglandin, while omega-3 fatty acids are cervonic, timnodonic, and alpha-linolenic. So cervonic acid is also known as docosahexaenoic acid, which is exclusively present in breast milk. Okay, which is present in breast milk. Apart from that, you have a lipid storage diseases. So how do you, I made a flow chart for the lipid storage diseases, which is quite easy. If not, it will be, you have to remember each and every portion. So here, coming to the lipid storage diseases, you have the sphingosine on the back. You have the sphingosine as an alcoholic backbone. So sphingosine plus free fatty acid is so called as ceramide. Sphingosine plus free fatty acid is so called as ceramide. So the ceramide is broken down by the enzyme called as ceramidase. ceramide is broken down by the enzyme called as ceramidase, and the deficiency of the ceramidase could result in Farber's disease. Deficiency of the ceramidase could result in Farber's disease, and then the ceramide will get an attachment from your phosphocholine. Ceramide will get an attachment from your phosphocholine, and ceramide with the phosphocholine will become sphingomyelin. Ceramide with the phosphocholine will become sphingomyelin, and sphingomyelin is broken down by the enzyme sphingomyelinase, and deficiency could result in Niemann-Pick's disease. Deficiency could result in Niemann-Pick's disease, where you see the cherry red spot on macula. Where you see the cherry red spot on macula. 2-year-old Jewish boy with a cherry red spot on macula. 2-year-old Jewish boy with a cherry red spot on macula is the one where you need to remember it as a classical vignette for your Niemann-Pick's disease. And Niemann-Pick disease shows increase in sphingomyelin. Remember, FMGE is not a tough exam to confuse you. Whenever they are asking you cherry red spot on macula and they are testing you, that is the time you need to look for increase in sphingomyelin. If they are testing Niemann-Pick's disease, there is always a sphingomyelin increase. Will be given on the clue. Look for the clues and get the answer straight. Okay, trust your clues. Most people makes the mistake is they don't trust the clues and they think like FMG people are so genius. They ask a very complicated question and they complicate their question and they choose 90% the wrong answer. Don't complicate yourself. It's a straight question. If they are testing you with the Niemann-Pick's disease, that means they are giving you elevated sphingomyelin. That means if they are testing you with the Barrett esophagus, they are giving you the, like a bird beak appearance. If they are testing you with achalasia cardia, they give you a bird beak appearance. If they are testing you with something else, for example, like a duodenal atresia, they may give you double bubble appearance. Okay, so trust the keywords and choose the keywords accordingly. Don't confuse or don't overthink on the questions that you don't know. Okay, so ceramide plus sugar can give rise to cerebroside. So cerebroside, if the sugar is a glucose, you get a glucose cerebroside. If the sugar is a galactose, you get a galactose cerebroside. So glucose cerebroside is broken down by glucose cerebrosidase enzyme, where glucose cerebrosidase enzyme deficiency is seen in Gaucher's disease, where you may see the two important key. One is your Gaucher cell, which showed wrinkled tissue paper appearance or crumpled paper appearance. Wrinkled or crumpled paper appearance. Crumpled paper appearance. And apart from that, you may also see Erlen-Meyer-Flask deformity of femur. Erlen-Meyer-Flask deformity of femur. Okay, so this is a glucose cerebrosidase enzyme defect. Glucose cerebrosidase enzyme defect will produce Gaucher's disease, where you see the wrinkled paper appearance or Erlen-Meyer-Flask deformity. Now, speaking about this galactocerebrosidase, alpha galactocerebrosidase and beta galactocerebrosidase. Alpha deficiency results in Fabry's, while beta deficiency could result in Krabbe's. Beta deficiency could result in Krabbe's. Then you have this cerebroside along with the NANA. Along with the NANA, you get a ganglioside. Along with the NANA, you get a ganglioside. And ganglioside is broken down by hexosaminidase enzyme. If it is a hexosaminidase A def alone, you get a Tay-Sachs. A or B def, you get a Sandhoff's disease. You get a Sandhoff's disease. Quite very, 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 very important MCQ. Okay, this whole page is kind of like a 7-star rated topic, people. You should not miss it. Okay, once you get the PDF, as I see the admin had posted that the PDF will be shared to you with the following WhatsApp number. So text him, get the PDF, and this page is also one of the 7-star rated page that you should not miss. Okay, so now these are the important images related to that. So we see that there is a Gaucher cell, which is showing the wrinkled paper or crumpled paper appearance here. wrinkled paper or crumpled paper appearance here. And then you see there is a Erlenmeyer flask deformity. Erlenmeyer flask deformity. And then you have the Fabry cells where you see the Maltese cross in the urine sediment and you see the angiokeratomas. And Krabbe's, you see the globoid cell and you see the optic nerve involvement. Okay. Then metachromatic leukodystrophy, you may see the tigroid appearance. You may see the tigroid appearance in the metachromatic leukodystrophy. And apart from that, onion peel appearance on Tay-Sachs and the foam cells on Niemann-Pick's and the cherry red spot on Tay-Sachs and Niemann-Pick's. Cherry red spot on Tay-Sachs and Niemann-Pick. These are the picture-based questions. They may ask you in terms of your Gaucher's disease. In terms of your lysosomal storage disease. Among that, this picture of your Gaucher cell, Erlenmeyer-Fast deformity, tigroid appearance, and your cherry red spot on macula, foam cells are the images that you should not miss. Are the images that you should not miss. Okay. This is all about your lysosomal storage disease, people. Now we are going to talk about the lipoprotein metabolism. Speaking of a lipoprotein metabolism, lipoprotein resembles your plasminogen. So lipids and proteins is so-called as lipoprotein. Lipids and proteins is so-called as lipoprotein. So next 15 minutes, focus, people. Next 15 minutes, focus, stay focused, because we are going to discuss a very, very important one and very, very easy one. If you miss it, you will not be getting the answers clearly. Okay, if you miss it, you will not be getting the answers clearly. It is purely conceptual and it is purely, you can score the score. If your concept is good, you can easily apply and you can get a good score out of it. Shall we proceed with that? Shall we proceed with that? Okay, now, speaking about it, so we call that as a lipid and a protein as a lipoprotein. So what is that a protein on the lipoprotein is your apoprotein, and what are the lipids you have is your lipids of your digestion. Okay, so for example, we are taking all type of lipid, and all type of lipids are broken down by your lingual lipase and gastric lipase and pancreatic lipase, and then they form the emulsification, and then along with the co-lipase combo, they get absorbed in the small intestine. That we studied in the digestion of your lipids. Yes or no? Inside the small intestine, all the dietary lipids will be packed inside the bag called as chylomicron. Will be packed inside the bag called as chylomicron. Now, this chylomicron is a bag which stays in the intestine. Now it have to come out of the intestine. Now it has to come out of the intestine. So in order to come out of the intestine, it requires a apoprotein. It requires a apoprotein. That apoprotein is so called as apoprotein B48. That apoprotein is so called as apoprotein B48, where this chylomicron will combine with this apoprotein B48. Chylomicron apo B48 complex will leave the intestine, and then it goes to lymph, and then from the lymph it goes to the blood. So blood is a circulatory fluid, right? Obviously collision will happen, right? So since the collision is happening, it will combine with ApoC2 and ApoE. Two other apoproteins will come and attaches with them. What are they? ApoC2 and ApoE. So in the blood, you have this chylomicrons. So this chylomicrons will be presenting along with that ApoC2, ApoE, ApoB48. ApoC2, ApoE, and ApoB48. Now this chylomicron have to enter into the liver, but the size of the chylomicron is a little bit larger. But the size of the chylomicron is a little bit larger, so it cannot be able to penetrate into the liver. So what it will do? It will look for the other component. Yes or no? It will look for the other sources. So what happens is, we have this ApoC2. This ApoC2, whenever it goes near the adipose tissue, this ApoC2 will activate lipoprotein lipase. This ApoC2 will activate lipoprotein lipase and takes the triacyl glycerides in your chylomicron and throws it into adipose tissue for the storage. So we have the chylomicron contains all the dietary lipids, right? For example, cholesterol, cholesterol esters, free fatty acid, triacylglycerides, fat soluble vitamins. Everything was packed inside that chylomicron. Am I right or wrong? Everything was packed inside that chylomicron. Now, this chylomicron size is too large, so it cannot able to penetrate into the liver. So, ApoC2 will go near the adipose tissue and says lipoprotein lipase that I am here and chylomicron is here. So, take some triglyceride and adipose tissue will transmit the triacylglycerides from chylomicron. Technically speaking, the enzyme lipoprotein lipase will take the triacylglyceride from your chylomicron and throws it into the adipose tissue for storage. Now, what happened? The chylomicron size will be reduced, right? Yes or no? The chylomicron size will be reduced, right? So the chylomicron will become chylomicron remnant. The chylomicron will become chylomicron remnant. So once the chylomicron has become a chylomicron remnant, what does it contain? Only the ApoE and ApoB48. Now the size is perfect enough to enter into the liver. So ApoE mediates the entry of your chylomicron remnant into the liver, and once it enters into the liver, it gets broken and all the lipids have been used up. And all the lipids will be used up. So far clear. We have a dietary lipids which is packed inside the bag called as chylomicron, and then the chylomicron have to move out of the liver, move out of the small intestine. So it requires apoprotein called as ApoB48. So ApoB48 chylomicron complex will come and bind with them, and then ApoB48 chylomicron complex will leave the blood, and then in the blood there are two more apoproteins will come and attaches with them. One is ApoC2, another one is ApoE. So we have this chylomicron with the three apoproteins C2, B48 and E in the blood, but the size of the chylomicron is too large to enter into the liver. So what happened? This chylomicron will tell the ApoC2, and ApoC2 whenever they come near the adipose tissue, they break the adipose tissue. They activate the enzyme called as lipoprotein lipase, where it takes the triacylglycerides from the chylomicron and pour it into the adipose tissue for storage. Now, this chylomicron size will be reduced and chylomicron will become chylomicron remnant. Now, this chylomicron remnant will have to enter into the liver with the help of ApoE, which has been attached to that. No problem. Now, the chylomicron remnant enters into the liver, where it broken down all of its enzymes, and then it throws all the dietary lipids and then into the body for the usage. Now, whatever the endogenous lipids which has been synthesized, for example, we have the sex hormones which broken down and produces certain cholesterol, and we have certain triacylglycerides which has been broken down in our body. So whatever the endogenous lipids has been present in the liver, it will be packed inside the another bag called as VLDL. It will be packed inside the another bag called as VLDL. Now this VLDL have to move out of the liver, right? It requires a apoprotein. What is that apoprotein? ApoB100. ApoB100. So this ApoB100 VLDL combo will enter out of the liver and then goes to the blood. And in the blood, again, same like a chylomicron, two more apoprotein will come and attaches with them, C2 and E. C2 will go and attaches with the adipose tissue, activates lipoprotein lipase, and then moves the triacylglycerides to the adipose tissue for storage. Now VLDL will become IDL. So this IDL may either enter into the liver with the help of ApoE, or this IDL may convert into LDL by interacting with the HDL. So this HDL contains a ApoA1. This HDL contains a ApoA1, which was wrongly mentioned here. This was a whole image. So ApoA1 is the one which activates the LCAT. ApoA1 is the one which activates the LCAT, and then it will convert the IDL to LDL. So LDL contains ApoB100, and then it interacts with the LDL receptor and throws the cholesterol inside the cell. So now we are going to talk about the Friderichsen classification of hyperlipoproteinemia. So So far, we have done with the apoproteins, lipoprotein metabolism. So what are the things we can write it in the lipoprotein metabolism? What is the function of ApoB48, which transfers chylomicron from intestine to blood, and Apo C2, activation of lipoprotein lipase. Okay. ApoE mediates the incorporation of the lipoprotein into the liver. So we used to write it like receptor lipoprotein interaction. And ApoB100 transport VLDL out of liver. And it is also the only apoprotein present in LDL. Okay. Then ApoA1 present in HDL. Activation of LCAT. Present in I rather write present in LDL and activation of LCAT. So these are the things you have to know. Then Fredrickson classification of lipoproteinemia. So B48 deficiency could result in, I rather write it in the red so that you can able to understand more. So B48 def could result in A beta lipoproteinemia. And ApoC2 defect could result in type 1 hyperlipoproteinemia. And ApoE defect could result in type 3 dysbeta lipoproteinemia. Apart from that, there is an important one, type 2A familial type 2A familial hyperlipoproteinemia. Is due to LDL receptor defect. You have to remember these things. LDL receptor defect. You have to remember all of these things. Okay, so this is quite important, and this page is quite important. You should not miss it. Okay, you should not miss it. So top to bottom, you have to remember every single thing. Okay, clear about that? So we have finished lipoprotein metabolism, lysosomal storage diseases, and then we have finished the entire carbohydrates in your biochemistry. So we pass for today, and tomorrow we proceed with the remaining stuffs like a fatty acid and thing. And tomorrow there will be one more subject, short subjects will be taken up. So we will continue along with it so that you can able to clear off the stuffs. Okay, any doubts so far? Okay, we wrap up for today, and tomorrow we will see you all people again.